this week on the BackTable podcast.
You know, when I'm sitting in tumor board and I'm listening to the pathologist and the oncologist go over all of these tests, all these molecular tests, all
I saw
of
your
these
eyes glazing a little bit, right?
Yeah, it gets very confusing. So I was kind of wondering, like, when you look at all of this data, there's a lot of data you're looking at. Is there an order that you're looking at in determining what medical oncological treatment plan you have planned for the patient?
A lot of this has to do with what is your pretest probability for what we're seeing. So if I see a patient with squamous cell carcinoma, I know that they're less likely to have any genomic alteration unless they're a non-smoker. They may still have one, but very uncommon. And the PD-L1 becomes kind of the most important thing. When I see a patient on the West Coast with adenocarcinoma, I am thinking immediately that I need to know that mutation status, and that becomes more important than the PD-L1 status for that patient because, again, there are 10 genes that we can potentially have targeted therapy for, and often we want to use those therapies before we use immunotherapy, and in some of these patients, especially our non-smokers, immunotherapy doesn't work very well.
Well, welcome everybody to another episode of Lung Cancer Creator Weekend. I'm Kavi Krishnasamy. I'm an interventional radiologist at University of Alabama, Birmingham. Do a quick round of introductions.
I'm Scott Atay, thoracic surgeon at USC.
I'm Scott Genshaft. I'm an interventional radiologist at UCLA.
Karen Reckamp. I'm a thoracic medical oncologist at Cedars-Sinai in Los Angeles.
Fantastic. Well, welcome everybody. Thank you for being here. This particular session, I think we're going to focus on more systemic therapies, what's out there and what's coming. So it's really an exciting time with the recent evolution. So let's start with lung cancer staging. You know, in the IR community, and Scott and I were talking about this recently, it's always interesting that there just doesn't seem to be as much interest in thoracic oncology in the IR community. We're both very big on thoracic interventions and very focused on thoracic interventions. So I think for our viewership, it'd be great to have a little primer on lung cancer staging, if you guys don't mind. You want to start, Karen?
We have a new lung cancer staging for 2025, and it's version 9, if you will, now. And every time we do staging, it tries to hone in on those areas where maybe there might be a new systemic or local treatment that might help to improve their outcomes. And so that's where this is honing in. And with the new staging, really, it got more granular in the lymph node stations and whether patients have one or more than one lymph node stations. But going back, thinking about the T stage, you know, we go from T1 to T4 based mostly on size, and where that cut period is for us is really the 4 centimeters or larger, and that becomes a stage 2 lung cancer when it's 4 centimeters or larger. And that really means that those are patients that benefit from more therapy and have worse outcomes. And then when you think about lymph node staging, single station lymph nodes and one lymph nodes that may be hilar or non-mediastinal lymph nodes. Then you have lymph nodes staging in the mediastinum. If they are ipsilateral, they're N2, and if they're contralateral, they'll be N3, and those N3 are going to be unresectable. And then you have the differential between N1, N2A and N2B, which are going to be multi-station or kind of single station and microscopic. And again, those single station microscopic, even though they're mediastinal, may be more amenable to surgery. And Scott can tell us more about what patients he thinks can go to surgery.
Yeah, so with the new staging, it helps break down, in a more granular way where patients sit, and the decision making then for us remains relatively similar in that a lot of surgeons had always said, well, we'll resect single station but not multi-station. But now we have a way to really name it within the stage, and that makes it more consistent. So other providers, and when we're having these discussions, we can be talking about the same stage and have the same sort of mindset. So patients with we'll call it regionally advanced tumors, so they have some mediastinal nodal involvement, but are limited in volume and bulk, we will still consider them a patient who can eventually have surgery as a component of their overall treatment plan.
And then the other area that has changed with staging with this new version is the metastatic staging, interestingly enough. And so now categorizing things as M1A, which is going to be within the chest, like pleural or multiple nodules within the chest. M1B, which is going to be a single solitary site, which again we've talked about before, but those are patients that may benefit from local therapy to that site. So that M1B is different. And now there's an M1C, which is going to be widely metastatic and thought about in a different way.
Fantastic. I appreciate that. That's great to kind of hear and try to comprehend, and these changes consistently come, right? And staying on top of them. It's also a little bit challenging. Let's switch gears a little bit. Molecular diagnostics, liquid biopsy, all these things are very, very hot, I think right now in a lot of different spaces, not just thoracic oncology. What does that exactly mean? And how do you utilize it? How do you both utilize it? You want to start, Karen?
We use liquid biopsy a lot. And so just to take a step back, in the era of modern thoracic oncology, we have 10 or more biomarkers that help us to determine the best treatments for patients. So lung cancer is not one disease, but many diseases. And so as you wouldn't treat a breast cancer patient without knowing ER/PR status and HER2 status, you shouldn't be treating lung cancer patients without knowing their genomic alterations and their PD-L1 status. So in this era, we are doing testing and often is on the tissue, but when we don't have enough tissue or sometimes we need to monitor for some reason, we are doing more and more of liquid biopsies. And liquid biopsies are in kind of multiple flavors. And so in the early stage setting, we're thinking more of a minimal residual disease, and so this MRD type of liquid biopsy versus in the metastatic setting where we're looking at ctDNA and say basically the circulating what is shedding from the tumor, which is a higher level of detection. You need a much lower level of detection for the minimal residual disease. So we're using those to think about prognosis, to look at the biology, to help understand whether we need to change systemic therapies, whether there are new targeted therapies that are available, and then again, it's an emerging area to use it in the perioperative and postoperative setting.
After a patient has a diagnosis of lung cancer, what kinds of clinical changes prompt you to attain another liquid biopsy?
So once we do it very often at the time of diagnosis, because sometimes the tissue results are going to take a longer period of time, or sometimes they're not sufficient to get what we need. So we're often doing it at initial diagnosis. And then generally for subsequent treatments, it is mainly right now in the clinical practice for patients who have oncogenic-driven non-small cell lung cancer, EGFR, ALK, probably the most common. And then we're looking for types of resistance mechanisms. One of the most common is a MET amplification, where we can add new therapies, things that can help us decide whether to change therapies that aren't histology-based. There are times where we also need to understand histology. Patients can have small cell transformation, and so then we need tissue and we need to understand that histology. But it's been very helpful, and because we are so molecularly based, have so many targeted treatments, patients understand that we need to understand the biology, and they appreciate the fact that they can get a liquid biopsy instead of a tissue biopsy at some points during their therapy.
Are you at times combining both a tissue biopsy and a liquid biopsy at the same time point?
Again, when we're thinking about what is causing the progression, sometimes we need the tissue. Again, sometimes for EGFR, ALK, they can develop small cell transformation. And so you may not find, often we'll do a liquid biopsy and see if there's something that we can target. If there's not that there, often we will move on to a tissue biopsy. But we can avoid tissue biopsy in some of those patients.
For liquid biopsy in particular, you need a tissue biopsy at the outset to then be able to do subsequent liquid biopsies, or no?
Not necessarily. So thinking about liquid biopsy and ctDNA, what we're doing for somebody in looking at somebody with known lung cancer, known metastatic disease, and we're watching it over time. We're looking for changes. We're looking for new genomic changes. And we don't necessarily need tissue, but obviously the tissue always informs what we're looking at in the blood. Because in the blood, you can have clonal hematopoiesis, you can have other types of you can have germline mutations, you can have other types of mutations that aren't necessarily related to what was in the tumor. So if you know what was in the tumor, that's important. When we think about minimal residual disease, there are also two types of minimal residual disease liquid biopsies, is one that is tissue informed and one that is not. And they're all, again, very ultra sensitive types of assays. So they're looking at different aspects of the DNA so that we can detect these tumor tissues earlier. But if you're tissue informed, then you really understand what's related to the tumor, and then you can better understand what's related to recurrence. So in the early stage setting, that tissue-informed liquid biopsy or minimal residual disease assay is really quite important for understanding what's happening later on.
Understood. That's a great point. Scott, how about yourself? Perioperatively, how are you using liquid biopsy?
Yeah, so I think those are starting to come into play for us in terms of deciding a sequence of therapies, meaning if somebody has mutations that are identified, do they need to be getting therapy beforehand? There's a lot of trials now that are looking at early stage patients who have driver mutations who get neoadjuvant TKIs. The big trial for adjuvant TKI Adura has been shifted to the neo-Adura, so now we know maybe we need to be knowing this in advance to be treating these patients. So for us, having an understanding of what the sequence of therapies should be and understanding what the expectation for therapy afterwards might be from our medical oncologist helps me make a decision about the right operation to do. Similarly, we have a lot of trials, or there are trials now looking at the use of liquid biopsies for higher risk early stage patients, where if you have a positive liquid biopsy or you have circulating tumor DNA and you're a stage 1, is that representative of somebody who actually does need systemic therapy? And is that person have a driver mutation and they should be getting it beforehand? So that helps me know, well, maybe I need to pump the brakes on this, get them back to our med oncs, and then they get treated first. Or is this someone where they really are early stage, they are a low risk candidate, we should just go forward and maybe give them the least aggressive operation necessary, a sublobar resection or something, as opposed to lobectomy, where we're informed by that information from your either liquid biopsy or simply your just genomic sequencing.
That's pretty interesting because I would assume out in the world, most patients who present with a stage 1 lung cancer may not get a liquid biopsy before treatment. Do you think that this is the direction we're going to go over time, that we're going to be getting that liquid biopsy to determine their relative risk of developing recurrent disease?
I think that as it becomes more economically feasible, it will be applied more broadly because I don't think it's such a low risk intervention. I mean, what patients may not love having a needle stuck in their chest, but they're probably okay having a blood draw. And so if they can get that done and we can get informed enough information to make treatment choices, then absolutely, I think it's going to become much more part of our standard sort of treatment plans.
And I think the challenge is we need those trials to help us understand what that means, because though we'd like to say this person does or doesn't need more therapy, we don't have that direct correlation yet. And so whether somebody does or doesn't have anything circulating, even on an ultrasensitive assay, we don't have that correlation to say, okay, we can forgo therapy, we can intensify here, we can de-intensify. But those are the things we're thinking about, or kind of the intensification or de-intensification of neoadjuvant or adjuvant therapy based on these liquid biopsy results. And I think that's absolutely where we're going. I think we're probably 5 to 10 years out from doing it. But like you said, once the cost goes down, the assays have better detection rates. It seems like a pretty straightforward thing to do.
Yeah. It's interesting, at least in the liver space, I know that we've not really run into cost issues. The companies that are providing these assays are really doing so for the benefit of the patient, which has been wonderful. I don't know if you both are seeing that in California in the thoracic space as well. But I know for me in Alabama in the liver space, it's been an easier hill to climb, I think, for us. So I want to switch gears a little bit. You mentioned, Karen, some specific mutations already, but let's talk a little bit about immunohistochemistry, next-gen sequencing, FISH, some of these other topics that I think are relevant in this space as well. Please take it away.
So when we're diagnosing a lung cancer, again, this is a hugely evolving field. But immunohistochemistry really, we want to know, is this adenocarcinoma, squamous cell carcinoma? So we're looking for things like TTF1 and NAPSIN-A for adenocarcinoma, P40, P63 for squamous cell. Those make it pretty straightforward. The other immunohistochemistry test that we do on everybody pretty much across the board. Again, early stage and late stage had potential implications as PD-L1, which is our biomarker to determine if immunotherapy is beneficial. Generally, in the neoadjuvant and adjuvant setting, we're going to use some immunotherapy if there's no other oncogenic driver, but having the PD-L1 level can help us understand kind of the magnitude of benefit that patients might have. So it's not a perfect biomarker, but it is still there.
For immunotherapy specifically?
For immunotherapy, very specifically, the PD-L1. And we're moving to new immunohistochemistry, often AI-assisted immunohistochemistry, and those are for some of the newer agents that we have out there, especially the antibody-drug conjugates. And so immunohistochemistry is evolving, especially in the new AI era. And so watch out, there will be more immunohistochemistry that we're going to need. One area is HER2, where we weren't really, in lung cancer, once we got the diagnosis, we didn't think about biomarkers in the immunohistochemistry area. And now we have the HER2 drugs are approved for high expression of HER2. So now we need to get HER2, and we need to get MET for another drug that was approved for MET overexpression. And so we're moving back into getting some targeted therapies for immunohistochemistry. I would say that FISH is really something where they're looking at probes and the expression of the probe. It looks at fusions and rearrangements best. And we're moving away from that a little bit more. They tend to be fast assays. And so in the perioperative setting, looking at FISH can be a rapid way to find things like ALK, which are going to determine treatment, because we use ALK inhibitors for adjuvant therapy, and you might not give them the neoadjuvant therapy if they have an ALK alteration. So FISH can be a rapid way of evaluating patients. But I think in the general next generation sequencing, as that's becoming more applied more frequently, we're generally doing less FISH on patients. And then we have our PCR, which we can look at mutations by PCR, which I think, again, are generally less often, but there's still some assays where they'll do single gene PCR. They're generally quicker than doing next generation sequencing of a whole panel. So sometimes, again, in the adjuvant setting, looking for EGFR quickly and a PCR may be beneficial. But then most of the time we're moving toward next generation sequencing, which is a large panel of genes, because like I said, we have 10 biomarkers that have targeted therapies. And so we want that full range, and we don't want to lose tissue along the way. So it's both DNA sequencing and RNA sequencing that give you the full panel of alterations. But again, in current lung cancer treatment, this is standard. Here, at least on the West Coast, we've done a very good job at making this standard. I know there's still a lot of uptake issues across the U.S.
Great points, but all require tissue.
So thinking about tissue versus liquid, the tests that we can do on liquid biopsy are the next generation sequencing, and the mutation testing and the fusion testing. So those we can do on blood very easily. PD-L1 not so much, and the immunohistochemistry are all going to be on tissue.
So what are you going to have to see with regard to liquid biopsies, which will obviate the need for tissue biopsies?
So it used to be tissue is the gold standard. I think we've already moved past that. That if a liquid biopsy is positive for something, especially an oncogenic driver such as EGFR or ALK, it's true. And so that can be a gold standard too. It's just the problem with liquid biopsies is that they're more heterogeneous, and you have other components in the blood that may start to distort what you see. So the tissue is more real source that way. But understand and tissue that we get from the surgeon is the gold standard, because that's the whole mass that we get. When you do a biopsy, you're getting a portion. And so we've seen this too, especially in people who have had prior treatments, that the tissue biopsy is not as informative even as the liquid biopsy. So we are seeing better and better liquid biopsies. But I think we will always need diagnosis. We will always need some aspect of the immunohistochemistry. And so tissue's not going away, but there are times where we can get most of what we need from the liquid biopsies.
It's very unfortunate, because I really am looking to do fewer tissue biopsies.
You were saying you were too busy, right?
One of the main goals I have in life. So that's somewhat disappointing.
You won't go out of business anytime soon.
Good. When I'm sitting in tumor board and I'm listening to the pathologist and the oncologist go over all of these tests, all these molecular tests.
I saw your eyes glazing a little bit, right?
Yeah, it gets very confusing. So I was kind of wondering, like, when you look at all of this data, there's a lot of data you're looking at. Is there an order that you're looking at in determining what medical oncological treatment plan you have planned for the patient?
A lot of this has to do with what is your pretest probability for what we're seeing. So if I see a patient with squamous cell carcinoma, I know that they're less likely to have any genomic alteration unless they're a non-smoker. They may still have one, but very uncommon. And the PD-L1 becomes kind of the most important thing. When I see a patient on the West Coast with adenocarcinoma, I am thinking immediately that I need to know that mutation status, and that becomes more important than the PD-L1 status for that patient because, again, there are 10 genes that we can potentially have targeted therapy for, and often we want to use those therapies before we use immunotherapy, and in some of these patients, especially our non-smokers, immunotherapy doesn't work very well. So then I'm looking at the genes. If I see somebody, again, the non-smokers are going to have different genes that I think are more likely or going to have a higher possibility than those people who are smokers. In the smokers, we tend to see BRAF, KRAS, and MET. In the non-smokers, we tend to see EGFR, ALK, ROS1, RET, and TRK, and NRG1, and then HER2. And so we have different thoughts depending on the specifics of the patient. Again, we have large Asian population on the West Coast, and those are largely EGFR positive. And so we're thinking of that, but we still can't know for sure until we get the data because it's not 100%. And so even if it's a 65% chance that a person of Asian descent, non-smoker in front of me is going to have EGFR, it still may not be. And so we still have to wait for that data to start it. But it's a complex decision. But the short answer is wait for the next generation sequencing as the first step. Don't act on the PD-L1 before you have that.
Understood. I think that from my standpoint, because the targeted treatments for EGFR and ALK have been around for so long, that's kind of like where I start and stop. But could you go into some of the treatment options that patients have for other mutations?
So, right, I would just go through the line. And so we have EGFR and we have EGFR tyrosine kinase inhibitors that are very beneficial, improve progression-free, improve overall survival. We are now intensifying therapy for patients with EGFR mutations. So we have additional either chemotherapy or added EGFR MET antibody that we give with TKIs. Then we have ALK, and we have a large number of ALK inhibitors that are approved. We have the first ALK inhibitor, lorlatinib, that has a more than 5-year progression-free survival. And so these are lung cancers that are different, than the lung cancers that you Google about and things like that. These are people who, even with metastatic disease, can live a decade. It's not unheard of. So really exciting. ROS1 is kind of it's near ALK. And so some of the inhibitors are similar. The outcomes for patients with ROS1 also very good. And we have a number of ROS1 inhibitors and one that was just recently approved, taletrectinib. And so they're getting to be more and more specific for the target. After ROS1, we have RET, which is also tends to be a non-smoking or light smoking alteration. We have TKIs for that. Also, patients do very well. The other piece of this is the TKIs go to the brain. And so even with brain metastases, we're able to treat and often delay, especially things like whole brain radiation. And then so after RET, we have MET, and we have TKIs for MET. And NRG1 is one of the newer fusions, and we have an antibody, a HER3 antibody for NRG1. We have HER2, which has mutations, and we have antibody drug conjugate and a TKI for HER2. And then we have KRAS, which is specifically the G12C, which has targeted therapy, and we have BRAF, which has combination targeted therapy. And I think I covered them all.
And that's just targeted therapy.
That's just targeted therapy, right? And then again, most of the other patients will receive immunotherapy. If they have high PD-L1 greater than 50%, we'll give immunotherapy often alone. And then if it's lower, we give immunotherapy with chemotherapy. And the amazing thing is that patients are living longer. Yeah. Like this is something in my career over the past 20 years has changed dramatically. Sure. So I have patients now that I have for years and years They tell me stories about their kids getting married and their grandkids and things. And in the past, 30 years ago, people lived a year. Yeah. And that was about as good as you could expect. And so we need to think about even toxicities of these drugs and long-term toxicities, which are things we'd never had to think about before. And then again, where this group comes in is we need local therapies because sometimes we get new local oligoprogression and things like that. And we're doing a lot more local therapies for these patients along the course of their disease.
Yeah, I think a lot of these patients present with disseminated disease, but there certainly is a subset who present with a solitary pulmonary nodule. How do you think about that, combining targeted therapy, surgical resection? What do you think about that, Scott?
Yeah, so I think with the targeted therapies, we're starting again to learn that giving them up front for many of these patients in the neoadjuvant setting is going to be the way to go. And those patients can still get resected, and maybe we're salvaging some lung, especially, a great example is the non-smoker EGFR mutant young female. So if I see a 45-year-old woman who has this lesion, it's an EGFR mutant tumor, and on the contralateral lung, there's this very, very vague little ground glass thing. In my mind, I have to think, well, they've got 50 more years of life. They're going to have another lung cancer. So how can we approach this surgically or locally, whatever, not to discount ablation. So how do we approach this locally in a manner to preserve lung to treat later? Because, this is something where she may end up with lung cancer number 2 or lung cancer number 3 or recurrence number 1 or whatever it might be, is what's going to be the optimal therapy to preserve, to allow for therapies again down the line. Same thing with knowing some of these different mutations. They are more or less likely to present with nodal disease. They more or less likely to be a little bit more aggressive. And so knowing that in advance allows me as a surgeon to make a choice about, again, sublobar resection with a more limited nodal field or lobectomy, which is a much broader lymph node dissection. Which one do we need to apply to render these patients disease-free? And then the far other side of that coin is the chronic management of the metastatic patient, right? Which is they're not binary outcomes anymore, right? We don't think, as a surgeon, we usually thinking surgery, no surgery, cure, fail, right? But it's really not. It's managing. So this is a patient, to your point of maybe they're an EGFR mutant and they're great, and then they have limited location of progression a few years down the line. Can we apply a local therapy now? Absolutely. We manage that site surgically or otherwise, and then we give them a few more years. And then another site, and then we manage it. And so now it's really, it's chronic disease. It's not a binary outcome. And then on the surgery side, it's really how do we limit the morbidity of our treatment, which can be morbid, and allow for further therapies down the line. TKIs are great too, because unlike conventional cytotoxic chemo, where even after a lobectomy and everything goes great, it's not fun to jump back on the chemo train 3 or 4 weeks later. TKI is much more palatable for the patients. They can initiate them earlier and they tend to do well.
Toxicities do occur. When toxicities occur, how do you view starting and stopping systemic therapy? And are there downsides as far as efficacy when restarting systemic therapy after a suspension?
So again, when we think about, I think we can put the buckets of targeted therapy, immunotherapy, chemotherapy, and those are the general tools that I have in my toolbox. And so when I think about targeted therapy, most of these, but not all, are oral therapies, small molecules, and they're pills that people are taking once or twice a day. So when you have toxicity with a drug that's oral, that they're on every day, it's easy to hold the drug and let the toxicities subside. We often try to do dose reductions when we can, but the issue is we don't know about efficacy. But again, the dosing is based, if you're a 300-pound person or a 90-pound person, the dosing is the same. Generally for these oral drugs, it doesn't change. And so sometimes people do need lower doses, but we don't have that information about efficacy. And the areas where we get the most concern is when somebody has brain metastases that we're trying to control with the oral therapy. And the brain metastases we don't know the level that they will still be controlled if we start to dose reduce the drug. So we try to keep the patients on the highest drug that they can tolerate. But as we've said, these are drugs that they're on sometimes for years, and you have to be able to tolerate it every day. And so just as an example, often with our fellows, somebody will come in and say, yeah, they're doing great. They have grade 1 diarrhea. And so my question to them is, grade 1 diarrhea every day? right? Because that's several episodes. So grade 1 diarrhea is, in general, when we give chemo, not a big deal. It lasts a day, it lasts 2 days, they get over it. Or grade 1 nausea every day, like that can be problematic, and people can start losing weight and start having problems when they have that level of low grade toxicity every day. And so we just have to remember that. And dose holds and dose reductions are the main way that we deal with that. For immunotherapy, it's kind of an all or nothing thing. So immunotherapy is a whole different world because immunotherapy causes an activation of your own immune system. And that's what we want it to do. But as we do that, we basically cause potential of autoimmune type of phenomenon in any part of the body. So when we explain to patients, we say you can get inflammation anywhere from head to toe. And that means encephalitis to, cellulitis to thyroiditis to anything like that. And so everything can be affected and there's no time frame. So usually with an oral pill or chemotherapy, you get the drug, you have the side effect. With immunotherapy, you get the drug 3 weeks later. 6 months later, you have the side effect. But it always is inflammation. And so our go-to for immunotherapy is steroids and then other immune modulatory agents if we need to. There's no dose reductions for immunotherapy, so we do hold it sometimes. Sometimes you have to hold it indefinitely. Sometimes holding it indefinitely doesn't make the toxicity go away because what we've already done is increase the immune activation. And so there are sometimes that we have toxicity that get potentiated. And so then you add other therapies to it, like radiation or even ablation, which may, cause some immune reaction. You may have untoward events that are not even near the tumor that may start to be activated. So I think immunotherapy is a challenge, but it still is very low toxicity and very manageable. But when it gets out of hand, it can become very challenging and hard to predict.
So for a patient that does have serious toxicity to their lungs, to the liver, to their brain on immunotherapy, and then it resolves, and then they reach a time point that they need to go on something, how do you think about restarting that? Or are you hesitant? Or what is that conversation like with the patient?
So again, most of the patients that I treat have metastatic lung cancer. And so that as a baseline is a terminal illness, right? And so we have these conversations and there is some data, maybe about a third of patients who have had that reaction will have it again. So we often do re-challenge once. And again, it depends on what it was. If it was grade 3 pneumonitis, probably not. But we do try to re-challenge people. And even we're pushing the envelope, patients with autoimmune disorders. As long as they don't have active autoimmune disease that is, that needs really heavily active treatment. Because again, they have metastatic lung cancer. Without if they don't have a targeted oncogenic driver, without immunotherapy, the median survival is a year. And so what's our other option, right? And immunotherapy for some people have 5-year plus. And it's a small percentage, but we still don't know those people. And so we're pushing the envelopes, having long conversations with these people, having their rheumatologists involved and making sure that we're doing the right thing. And we're trying to push the envelope because, again, you're going to, what are the options we have here? What are the outcomes that we could see? And again, without giving targeted therapy or immunotherapy, we're going back to the 1990s of treating patients and palliating them for a short period of time before they are dealing with end-of-life issues.
Another clinical presentation that I've seen far more than once is patients with solid organ transplants. What are your thoughts on treating those patients?
I would say
with
that's probably
immunotherapy specifically you're asking, or just in general?
Yes.
That's probably one of my least favorite categories. I think for the most part we're avoiding immunotherapy in these patients because we can do far worse things. But often, going down on their own anti-immune agents could be beneficial. But I don't see us using a lot of immunotherapy in these patients.
Yeah. I mean, my other hat that I wear is as a lung transplant surgeon. And so it's not super common, but they can't give it to those folks. They don't tend to do very well. So yeah, you have to withdraw immune suppression and cross your fingers, but the immune suppression itself just drives those tumors forward of whatever kind they are. They can be relentless in management. So
I don't want to sidetrack this, but I would really like to hear at some point your thoughts on lung transplantation in patients who have cancer in the lung.
Yeah.
question. Great question.
So that's a great question, and I'll give a not great answer. But what I mean is, so that we don't know, right? There is an ongoing trial out of Northwestern. They have transplanted a few patients who have had isolated disease to the chest. The trial, if I remember it correctly, includes really almost any histology that is lung isolated. The difficulty is really just understanding, I mean, again, it's a systemic disease. How is it going to be manifested only in the lungs? And then after you take out this tumor with both lungs and then put in a set of organs from another human and then immune suppress them to the floor, that any amount of tumor that's residual is not going to rapidly progress. And I guess the short answer is we don't know, because they do have some survivors. And I think we've all probably seen, I mean, you've certainly seen patients who just relentless progression in the lung without any systemic disease elsewhere. We see it in sarcoma, see it in colorectal, you can see it in lung. And in fact, that lung was, I think, at least 2 of the reported cases out of Northwestern were lung. So I don't know. It's a tough field. And then that other piece of it becomes the ethical consideration of a extraordinarily scarce resource and when to apply it. And is it worth applying it to someone who may otherwise have a terminal disease that could rapidly progress? I don't know the answer. So I think the jury is definitely still out. I don't know when that trial will mature and or accrue, because there's such a fine window to get that patient population. But it may eventually, there may be a very small subset similarly where we don't know who that M1B patient is who's going to be alive in 10 years. So we don't know who that one lung-only progression patient is who could get through a bilateral lung transplant, get immune suppressed, and not recur.
I think one of the situations that has always bothered me, because it comes up in my practice, are patients with advanced lung disease, fibrosis or emphysema, have a tiny ground glass nodule, which is probably lung adenocarcinoma, but is also probably not something that's going to kill them. And they want us to biopsy that nodule to basically prevent that patient from getting a lung transplant, and you're sealing the fate.
Yeah.
Certainly there are lung cancers that are removed on explant. Do you know offhand what the rate of that is?
It's very low. It's very low because all programs because we are held to a very tight standard with publicly reported outcomes related to, again, appropriate utilization of a scarce resource. All programs are extremely tight to make sure that candidates really fit in the box. But that said, I have explanted a lung with a cancer in it that we said this just looks like a bunch of fibrotic changes, and then the final path comes back a week later and they say, actually, there's a small adenocarcinoma in here. It is what it is. I think you will encounter that. But to your point, I mean, you are asked to do a higher risk procedure on a fibrotic lung that comes with more risk of pneumothorax and bleeding and everything else. And that also will eliminate their candidacy for this organ. It's a tough call. I mean, but most programs will aggressively pursue that. I mean, I, as a thoracic surgeon, have had to do that operation on patients who are candidates for kidneys or livers or whatever else, because they said, we just have to know what this is. Can you please take it out? Even within the ablation space, we had, I can think of a case where there was a lung cancer, biopsy proven, very early stage. They said, look, we need this to be treated. We said, well, it's a heart transplant candidate. I'm not going to operate on them. Well, if you radiate it, there'll still be a lesion. We can still see it, so that we can't do that. It has to go away on the scan. We can't have, and so it's tough. It's a very tough situation for those patients because they now have 2 potentially life-threatening illnesses, and can you manage them both?
It's just interesting to see how this space matures, since we've been working in the liver space for so long, for which transplantation is just curative for many patients with HCC.
Yeah. Karen, I had a question for you. West Coast population, I assume you have a predominance of Asian patients. I don't know how many native Asian patients you see. What is the impact of lung pollution in this patient population?
So that's an incredibly interesting question. And, so we have, not only do we have Asian patients, whether they're first generation or immigrants, but we also have non-smokers that are non-Asian, because on the West Coast, we've had more laws about smoking for longer periods of time. And there's clear research that's coming out of Swanton's group in the UK that is looking at particulate matter and really does show a relationship, especially to the EGFR mutation. And so it's a very difficult area to tease out, because obviously you have smoking, you have pollution, you have other potential causes. But thinking about the fact that especially where we first learned about kind of non-smoking lung cancer was in the Asian female population, and especially the group from China, because there are just so many. And again, the pollution levels are high, and we don't have a lot of other explanations. There's a small cohort that may be familial, and we're just starting to get to understand germline. Obviously, in other tumors, we have a lot of understanding of germline. In lung cancer, we're far behind, and that's partially because of the smoking stigma. I remember when I was a fellow, we said, who in your family had cancer? And they said, oh yeah, my dad had lung cancer, my grandfather had lung cancer. Oh, but they were smokers. And I don't even know if we wrote it down. We're like, okay, of course they had lung cancer, right? So we're understanding genetics, but the pollution levels are clearly starting to be tied to these non-smoking lung cancers.
Fascinating. And then going back to that smoking population, what do you now tell patients that were former smokers? I mean, obviously the risk is increased, but let's say they stopped smoking 30 years ago.
So, the further you're out, the better you are, but you never get back to normal. And so they're always at some risk. It's interesting. Immunotherapy, unlike people who are non-smokers, immunotherapy doesn't tend to work all that well for their cancers. Immunotherapy tends to be more active in people who have had smoking histories. So now the true negative impact of smoking is a little less so that we have immunotherapy. But all of the studies show your outcomes are worse if you continue smoking. So we obviously push on that. But the risk for lung cancer doesn't ever go away completely.
Yeah. Well, and I would almost argue there's almost now a stigma on continuing to smoke in the U.S. I mean, I don't see a lot of smokers in the U.S. anymore. I mean, my wife lives in New York City, and every time we travel to Europe, it is so predominant in Europe, but I just don't see a lot of smokers in the U.S. anymore. And, credit to changes in laws and things that have happened over the last 10 years.
And you're in Alabama. So
and I'm in Alabama,
yeah.
Exactly, right? So,
I mean, I think it's good we see that. But what's interesting too is when you look at like Sears outcomes for incidence, is that drop in that reduction in smoking has led to a pretty significant change in the incidence of lung cancers in men, but that the women, it is just flat. It is not impacting that. One, obviously, because there's fewer women smokers, but there's this huge chunk of this never smoker population that is still, native, whatever their risk factor is. But yeah, the men, you can see that curve drop off, and in women, that curve is just staying flat.
That's fascinating. And we'll know more over the next 5 to 10 years, right? I mean, there's so much we still don't know. But on the topic of immunotherapy and evolutions in therapy, we talked a little bit about Checkmate 816 and the Pacific trial earlier. Can we go into depth a little bit more for those two, and anything else that, in the last 5-6 years that has really been landmark? I mean, I know there's a lot. That's a lot. I apologize. But anything that for you in particular, and you, Scott, as well, that really just, wow, this is amazing data.
So I think the biggest thing, so immunotherapy has been available now for a decade. Interestingly, it was approved first in 2015 for lung cancer. And so we've had it for a decade. And obviously in the metastatic setting, it has been transformative, and we have people who can have long-term benefit, even though if they're small numbers of people, they're long-term benefit. But really the big change is moving this into the curative setting. And so now we're getting more what we're willing to call cures. And so using it in the neoadjuvant setting, so the Checkmate 816 is neoadjuvant only, and it's chemotherapy with nivolumab, and you give it before surgery. And then again, the 20 to 25% who have complete pathologic response have exceedingly high overall survival, or 5-year disease-free survival. And that's kind of the cure number that we use. And then there are a proportion of patients who are benefiting, who aren't getting complete pathologic response. That area we don't understand quite as much. And then you have the studies that have done neoadjuvant chemoimmunotherapy, followed by resection, followed by adjuvant, more immunotherapy. And that's kind of where we're trying to understand, do we need more immunotherapy? That's where we're using these minimal residual disease assays to understand, do these patients need more intensification? Do they not? Do those patients who have complete pathologic response need any more therapy or not? And so those are the areas we're going to try to cure more patients. And that's in the targeted setting also. We now utilize osimertinib in the adjuvant setting and alectinib in the adjuvant setting for ALK patients. And these are leading to improvements in survival, which is really remarkable. The challenge there is, does this extrapolate to other genomic alterations? And do we need trials to do that? And when you get down to ROS1, HER2, things like that, these are small populations. These are patients who live a long time and do quite well anyway. And then are you going to be able to have that trial? And when is that going to read out, decades from now? And so I think we're kind of thinking about utilizing the drugs that are least toxic, that have the highest efficacy. So something potentially like RET or ROS1 may be the areas where those things might be extrapolated. But again, we don't have data there. But I think the key change in the last 5 years has been moving these agents that we know are improving survival in the metastatic setting to the early stage setting for patients. And then there are new agents coming out. We haven't moved the needle in the metastatic setting since we've had immunotherapy in a major way. We're looking at antibody drug conjugates, some of which have biomarker driven, some of them that are more general, and other types of immune type of T-cell engagers and things like that that can activate the immune system in a more powerful way to kind of get more of these patients across that line to have longer term benefit.
It's a great point. And we don't, Scott and I don't just see this in the thoracic on our side with local regional therapies in the thoracic populations and other organs as well. I mean, again, survival, as you said, is very long. How do you compare therapies? It's a challenging proposition today because in 10 years, all the therapies are going to change, right? And then is that data relevant anymore? So that's a tough one. How about yourself, Scott? Any big trials in the last 5 years that have really affected your practice?
Well, I mean, I think all the neoadjuvant trials really, that has driven we used to operate up front for really anything except for your 3As. Really, once you hit stage 3, we said, you're going to need to get some neoadjuvant. You're going to get neoadjuvant platinum doublet. The response rate's going to be what it is, and you're going to resect them. Now, anybody really with local regional disease at all, you're going to send for neoadjuvant therapy. Aside from your 1As, 1Bs, once you get to stage 2, that is what was enrolled in these trials. So we're operating on those patients after therapy. The toughest part as a surgeon is if they see me first, which again, sometimes happens. They come from the pulmonologist, we stage them, and I say, I want you to see the oncologist because I think you should get chemotherapy, immunotherapy first. Is they, without fail, say, well, why can't you just take it out? And that's the hardest sell, is to get someone where you can say, well, yeah, we can do that. And that's what we used to do. And that's what we still do sometimes. But you probably will do better. Your long-term outcome is better. And it's very hard patients don't, again, see that 5-year horizon. That's just not where their heads are at. They want it out tomorrow. And then if it's out tomorrow, that means they're cured. And then whatever happens. And so trying to tell them the percent chance you're going to be alive goes down by 15 or 20, whatever the number might be for that individual. It's hard for them to quantify that. And so they really are hesitant. So we, for example, within the space of the trials, our program has always struggled to enroll neoadjuvant early stage patients. Those trials are very hard to convince someone who's a 1B, can you go get neoadjuvant therapy? This is nice, just take it out and let's be done. So that's where it has impacted us a lot, is trying to get patients the right therapy. In terms of the operations themselves, they are assuredly less pleasant after immunotherapy in many cases for node-positive patients. If they're node-negative, it's really not all that big an issue. Node-positive patients, it tends to be a little bit more fibrotic. You do see that pseudoprogression, that inflammatory response that makes everything a little bit more challenging. But like everything else, that has become more of the commonplace. And so really, our outcomes and the studies have shown that the outcomes are the same. The operative outcomes are no different. So we just are prepared to be doing those operations in that setting. And we just have to really be working with our oncologists to make sure they're getting there first. If the patients see oncology first, that's great. Then, I see them down the line. But if they see me first and then try and shift gears, they're coming with an expectation they're getting a definitive therapy today,
That's a great point, and it kind of gives rise to the conversation about multidisciplinary clinics. And we kind of alluded to this one earlier. Do either of you have a multidisciplinary clinic?
We don't have a specific multidisciplinary clinic just for the logistics of where everybody is
That's
located.
The problem.
And so we more rely on the quick consults from my clinic to the surgical clinic. We often have people in the clinic on the same days so they can get from one place to another. And our radiation oncologists will come upstairs and come to our clinics, but we don't have it in one place right now.
Yeah, we do it as we have a multidisciplinary clinic. It happens to be our oncology clinic.
Okay.
But we basically just staff it to make it functional. As MDC is 1 day a week, and I'm on for MDC one Friday. My colleague, he's at the MDC the next Friday. So there's a surgeon there, there's an oncologist there, there's a rad onc there, and then invariably pulmonary or interventional radiology for specific cases. But we just sort of say, we have our cancer navigator. Usually it's a tumor board case where we run through it in a tumor board and say, this is an MDC case, put them on for next Friday. The navigator will sort everybody out, and then everybody's able to see there. But yeah, it's logistically challenging, so we don't really have it as a consistent thing. I go to the MDC like once a month because that's just the day that I'm there as the surgeon for that clinic.
Yeah. That's a great point. I think, Scott, I'm curious how you guys do it, but for us, we have a lot of liver we have a neuroendocrine multidisciplinary clinic, we have an HCC multidisciplinary clinic, we have a colorectal multidisciplinary clinic, and it's slowly growing to other spaces as well. But as you said, logistically, it's a challenge. And I'm not in clinic once a week. I'm in clinic once every other week. So that also, for me personally, as a person that does most of the thoracic interventions in my practice, that becomes challenging as well. How do you guys do it?
We have a multidisciplinary clinic for thoracic oncology. I don't attend it. It's just logistically nearly impossible for me. I think that's a big issue with these, large health systems. It's certainly fantastic. I would say from an interventional standpoint for lung cancer, yes, I think that our input would be invaluable with regard to acquisition of tissue, with regard to local therapy. I tend to see that the hit rate for us, frankly, in acquiring patients in this setting is fairly low compared to certain other settings, other tumor boards, other multidisciplinary clinics for other cancer subtypes. And so that's the balance. It's probably fantastic for patients and fantastic for the team, but for interventional radiologists as individuals, not high yield.
I think it's just kind of the trickle, the next layer after the tumor board, right? If you have a good functional tumor board, a lot of those multidisciplinary decisions kind of get pinned down. And then if they need to see more than one specialty, we will funnel them in if it works. And honestly, there are some times where it's just like, look, I'm not available, they're not available. They're just gonna have to see us on different days or at different times, and that's okay. But I think as long as you're collaborative in the decision making, whether we're standing in the same room or not, it's fine. I mean, sometimes if we have patients traveling from, they're coming from Mammoth, let's get everybody hammered down in one day. But if they're local and, even if they're doing telehealth visits, then, it's just easier.
I will say anecdotally, post-COVID, where everything is Zoom-based, if you have 4 or 5 people in a room in a multidisciplinary setting, getting ready to see the same patient all together, or, not together, but sequentially, anecdotally, I feel like the conversation is much more educational. It is arguably sometimes even more collaborative. So I actually love going to multidisciplinary clinic. But again, as you said, there are a lot of logistical challenges.
And in our RVU-based culture, it is really not the most efficient way to move patients through a clinic.
And that's definitely tough for so much HMO penetration for California. Yeah. You can't get an HMO to let you see all. If we say, well, you need to see radiation oncology, surgery, and medical oncology, they're going to say, well, we're going to pay for your med onc visit. And then if they refer you, then we will maybe give you an authorization to rad onc. And if they say no, then we'll author it. So you're jumping through a lot of hoops to get everything. Yeah, it's not an efficient way to do it.
Karen, I want to go back to this oligoprogression, oligometastatic thought. I agree with you wholeheartedly. If we can keep a patient on the same line therapy or the same therapy and then just go after the progressive disease or clear the metastatic foci in limited fashion, 100%. But what data do we have that supports that?
So the first study that came out was the Gomez study, and this was really for patients more in the immunotherapy era and more than targeted therapy. So there's studies that are targeted therapy, immunotherapy, or either both. And so, again, many of these studies are not so uniform in the way that they've been implemented. And that allowed for, just to take two steps back, there's kind of two ways that people think about it. And it's very subtle and sometimes hard to tease the two apart. But there's consolidative local therapy, and then there's local therapy upon oligoprogression, right? And oligoprogression meaning probably usually less than 3 sites, definitely less than 5 sites. Yeah. Again, all of these things are dependent on the specific trial. And so the consolidation was really the Gomez study, where they were consolidating sites either surgically or with radiation after initial therapy. And then you're going back to say, where was the disease, even if it's not there anymore, and we're going to start to go after it, which again is a little tricky sometimes if the disease isn't actually there. And so a lot of lymph node stations that are being radiated and things like that, but with maybe they need to, maybe they don't. But again, improvements in time to the disease progression. And then other trials that have looked at it upon progression and looking at just the targeting of oligoprogressive sites. And again, these trials are different, whether it's 1 to 3, whether it's 1 to 5, whether they include brain, whether they don't include brain, and what sites. Sometimes bone is not included, what sites in the lung are included. But so again, invariably, there are a number of studies, both for targeted therapy and immunotherapy, that have shown improvement in time to progression, less often showing actual improvement in final overall survival. And the subsequent therapies are very different too for these patients. So again, we've had immunotherapy patients who may have great response for a year and a half and then have a oligoprogressive site, or they may have a response for 6 months and then have an oligoprogressive site, which I think are two very different patients. And the patient with only a 6-month benefit may be more of the patient who's going to progress more rapidly later. And then the targeted therapy, again, whether it's an EGFR versus an ALK or a ROS1, the ALK or ROS1 are going to probably do better for longer no matter what. And so you can't take these as one. And so I think the heterogeneity is the challenge. But I think overall, we all have cases where patients got either a resection of a lobe or a resection of an adrenal, or radiation or ablation to a small nodule or something in the liver. And we ablate the liver a lot. And then they have long-term benefits. And again, the problem is we remember the patients who are alive, the ones that continue to progress, that we did the ablation, they progressed, and then they didn't survive. Those are not as etched into our memories because we're not seeing them anymore. So it is challenging to know the true benefit, but I do think it improves patients' quality and time.
Sure. And I think from my standpoint, 1, 3, small number of sites of progression, I think it's difficult to define what that number is. It's just an overall disease state and trajectory and acceleration time of disease occurring. I have a low threshold, particularly with this data that's emerging, to do a therapy. Because what we do in IR is generally very low impact, moderate sedation, done in my outpatient center, leave 2 hours after the procedure is done. Where we have to put on the brakes in IR is chasing systemic disease. That is not successful. Yeah. You always have to come from the framework, if everything's working out well, can I make a positive impact? Yeah. If the answer to that is no, you must stop.
Yeah. Well, there is a test of time component to all of this, right? And I think to your point, if there is disease stability for a longer period of time, that maybe that argues for some sort of local therapy. But if there's rapid progression, yes, exactly, right? So, but I think the other thing, Karen, that you mentioned, this kind of concept of multimodal therapy, and I think not necessarily us at the table, but maybe in the community, we kind of get locked into this one therapy for everything that we see. And in reality, it's not. I mean, I refer to my surgeons, I refer to my radiation oncologists, I refer to my colleagues in IR that do other things as well, and so we mix and match therapies for the right tumor in the right location, the right patient, and that concept, I think, sometimes gets lost.
One area where we have, and again, we have a large number of EGFR patients, and they often have multiple micronodules, and they're on their TKI for 2 years, and then all of a sudden these micronodules start to appear again. And they're not, they're 5 millimeters, 6, 7 millimeters, and they grow a few millimeters every few months or so, and they're really not causing any symptoms. And they're not that they're throughout the whole lung, but there's a number of them, more than one or two, right? So often these are ones that we think, let's just ablate it, right? And let's just get rid of it. Let's not look at that anymore. And I know, so those are the ones we have some challenge. I mean, obviously, and patients want them gone, but is this a bigger picture? And then the other question is just, there are some now modalities where you can ablate and then potentially have the abscopal effect. Is that real? Can we treat these, multifocal nodules? And is there a better or worse way of doing it with ablation?
So these are great questions. These are questions without definitive answers. My personal opinion is smaller is better. In the ablation world, we often talk about how big can we treat? That's not the question that should be asked. The question is, how small can we treat? And the answer is very small. If you see it, you can treat it, and the overall treatment zone is very limited. So for the example of multiple lung cancers, for example, it is not uncommon for me to go in and treat maybe 5 in one setting. But the amount of total energy I'm depositing in the lung is very minimal for a 5 millimeter tumor. We're talking about a 1 minute ablation, typically a microwave ablation. The question of whether we treat with microwave or with cryo, that is unanswered. They are both equally effective. There are certain preferences with regard to patient comfort that will go into in more depth in another setting that sometimes favors cryo, but microwave is certainly, comes with it being much more quick. From my standpoint, I believe in the abscopal effect, and I definitely don't believe it can be controlled. There's a lot of devices that have come onto the market lately that are really promoting that they cause an abscopal effect in a positive fashion without any data whatsoever. And the reality is probably the best data that exists is for cryo, which has existed for, multiple decades now. And so I'm always suspicious of going for the abscopal effect. We have these patients we've been treating for 10 years and we'll want to give them one last shot and hope for the best. And guess what? That doesn't work. At the same time, we all have a case or two in our back pocket where we saw the abscopal effect and it was not predictable.
But I never walk into a clinic visit and say that and promise that. Frankly, I don't even discuss abscopal effect with my patients. I do get a lot of patients that, are thinking about going elsewhere for something like histotripsy because of that thought of abscopal effect. And I find it very hard to condone that. Let me put it that way. So that's a great point, Scott. That's really a tough one. I want to end on one last question. This concept of trials that show progression-free survival benefit but don't show overall survival benefit. What do we do with that data?
Yeah, good question. It's tough because I think just in terms of how trials are being run now, the field is progressing extremely quickly. So how do you enroll a trial that will impact therapies in the short term and progress the field more if you have to wait 5 years to accrue and 5 years to whatever? So finding surrogate markers is important. And so progression-free or disease-free survival is a quicker, you can be shorter, than an overall survival. And so you want to do that, but then you don't know. Same thing with major pathologic response or path CR rates. Again, we assume those all mean long-term survival. Turns out past CR probably does. Does MPR? Maybe, right? So how do you interpret that? Well, I think my opinion would be, even if you have a trial that shows good outcome for progression-free or disease-free survival, but an equivalent overall survival, the reality is that having a disease is not without morbidity. Many intrathoracic recurrences can be morbid. You can have pain that you end up having to treat. So there is an advantage, even in the absence, I think, of an overall survival advantage, to not having tumor. You can get longer until your next therapy. If you develop a symptomatic bone metastasis, that's unpleasant. Yeah, you can get it treated, but you still got to get it treated. If you get an extra year before your pathologic fracture, that's good. So I think there is an advantage to it, even if, yes, they're not living longer, but maybe they're living better while they're living. So I think that you just have to interpret those trials in a different context for the patient. I don't think it means it's a negative trial. I think it just means it's a different result, and you have to look at it that way.
So I would agree with all those sentiments. And it's really about, again, I'm thinking about it more often in the metastatic setting. And so it is about how do we improve length of quality life, right? And so length and quality are both relatively equal. And some of these patients are in it for the long term because it's not a year and it's over. It's over longer periods of time. And so when we're thinking about progression-free survival, toxicity comes into play. What are the toxicities? If they are more toxic and they're not living their lives, so a patient's not in their life, then it's probably not worth the progression-free time. If they're minimally toxic agents and they can improve symptoms in some way and help them live better, that's probably worthwhile. In the frontline setting where we, give our first treatment for metastatic disease, I think overall survival is going to be important because we have reasonably well-tolerated therapies. And so the toxicity piece and trying to get to that progression-free and overall survival is important. One of the areas where we're grappling with this is actually in the EGFR setting. So we have intensification therapies for EGFR. For the last almost decade, people have been using osimertinib, and there are many patients who get years off of osimertinib, brain mets, multiple mets. They get years, they're living their lives, they see us every few months, they get scans every few months, they go travel, they work, they do whatever they need to do. And now there are trials that show both an improvement in progression-free and overall survival by adding chemotherapy or adding more EGFR antibody therapy. And what you get is invariably more toxicity, but not only that, more cost and more time at the doctor. To tell you the truth, when you get diagnosed with metastatic lung cancer, it's a devastating thing. When you start on osimertinib and you're living your life and you're traveling and you're working and you're doing your thing and not thinking about the doctor every week, every 3 weeks or every 2 weeks, whatever the treatments are, it's freeing. And then you don't have a whole lot of toxicity. Now add toxicity, add doctor's visits, and now you have cancer every day, right? So there is a existential piece of this. And I guess for us folks who've been doing this a long time, there is some nostalgia to saying, but these patients lived really well. And we don't know that progression-free and overall survival, if I start these therapies later, could it be just as well? Because none of these trials have that therapy followed by another therapy that exactly matches what we would do in the clinical setting. But you're giving this really life of doing really well off of a lot of surveillance and a lot of toxicity, and you're trading that for a lot more toxicity for that reason.
That is a wonderful, wonderful point. So many questions we don't know the answer to, so many questions that we have learned the answer to in the last 5 years, but it's validating and gratifying for those of us at this table and those of us in the community that are passionate about this space. So excellent. Well, super well said. So with that, let's close the session. Thank you both, and fantastic discussion as always.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC, that's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe D'Agrazio,
Josh Spencer,
and Jaden White.
Design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.